So our next presenter, Dr. Tavishi Singhal.
Good morning, everyone. I would be talking about the clinical outcomes of retropupillary iris claw IOL fixation in the pediatric population. Starting off, as we all know, insufficient capsular support in pediatric aphakics, where in the bag or sulcus IOL implantation isn't an option. We have three main positions where we can put. Either it can be anterior chamber IOLs, scleral fixated ones, or iris claw, which can both be prepupillary or retropupillary. For our study, we went ahead and performed the retropupillary fixation as from the previous studies, AC IOLs in pediatric cases, because they need to be adjusted according to the white to white, and with the ever-growing pediatric eyeball size, it has been seen that there have been a number of complications like the IOL decentration or corneal decompensation. As far as scleral fixated IOLs go, with the limited amount of retrospective studies, and in our case, as we'll see, the most common differentials for our cases, the diagnosis were ectopia lentis, in which we all know there is low scleral rigidity, so that would have affected the scleral fixated IOLs. What was the rationale behind our study? There has been a dearth of prospective studies in retropupillary iris fixated IOLs in pediatric population. So with our ambispective study, we are here to answer the question if they are safe for pediatric aphakics. Based on the literature review, as I've spoken previously, there are a number of retrospective studies which have shown good results in terms of clinical outcomes, which is BCVA, the mean refractive spherical equivalent, IOP. And so we performed an ambispective study where we took 50 eyes of 28 patients, and it varied from January 2019 to August 2021. And our objectives were, the first objective being to describe the clinical outcomes, and following parameters were used. Best corrected visual acuity, IOP, the pupil size, IOL position on UBM, any complications, which was our secondary objective. So intralenticular lens aspiration followed by anterior vitrectomy was done. The main incision was 5.4 mm, and as we are performing a retrofixation, peripheral iridotomy was not recommended as from the literature review. Results, the differential diagnosis most common was ectopia lentis, followed by microspherophakia, and a few cases of surgical aphakia, dislocated ACIL, and post-traumatic subluxation. The best corrected visual acuity at a mean follow-up of 15 months was 0.30 logmar. The mean IOP was 13.63 at our last follow-up, and the important point here is there were no post-operative IOP spikes. Refractive error, the mean refractive spherical equivalent was slightly hypermetropic. We had performed an undercorrection of about 1.96 depending upon the age of the patient. Suture removal was done at 4 to 6 weeks post-operatively, and here we can see the spherical equivalent from post-op day 1 to our last follow-up was plus 1.12 diopters. The pupil size, as we can see, it is not hampering the dilator pupillae function, because the pre-op and the post-operative pupil size did not interfere. It did not change. It was not significant statistically. It varied from 7 to 8 mm, and we could easily visualize the fundus. There was an endothelial loss of about 2.8% over our average follow-up of 16 months. The effective lens position varied from 3.35 mm to 5.20 mm. It varies because of the difference in the axial length of the patients. Coming on to the complications, we have the most common being horizontal ovalization of pupil, which became circular in every case of ours at our last follow-up. The reason for this horizontal pupil ovalization was probably because of the slight tighter tucking of the iris claw or close to the pupillary rough. Other complications were corneal edema, which was because of the prolonged surgical time, but eventually it was all okay. 5 eyes had disenclavation, which was 2 were post-traumatic and 3 were spontaneous, but all of them were successfully re-enclaved, achieving a best corrected visual acuity of 612 or more. So to conclude, we infer from our study that it is a safe method of IOL fixation in pediatric population where there is surgical or traumatic aphakia with insufficient capsular support, or in children with subluxated lenses, provided the iris sphincter anatomy is normal. The limitation.
Let her finish. Let her finish.
Sorry, ma'am.
Finish.
Okay. The limitation being we require slightly longer follow-ups to ascertain if there is any kind of iris atrophy or pigment dispersion, which was not seen in our study with a limited follow-up of 16 months. Thank you.
What was the age of the
Ma'am, the mean age was 8.32 years. It varied from 5 to 15 years.
Which institute have you done this?
Ma'am,
study?
AIMS, RP Center.
Okay, thank you.